Hello, everyone. The Coordinating Center for the National Drug Early Warning System and the National Institute on Drug Abuse welcome you to our fourth monthly NDEWS Presents webinar. The NDEWS PI, Dr. Eric Wish, NIDA project scientist Moira O'Brien, and the rest of us at the NDEWS Coordinating Center are very pleased you could join us today. My name is Erin Artigiani, and Kathy Garcia and I will be the facilitators for this webinar. We are a part of the Coordinating Center team for NDEWS, which is supported by funding from NIDA. For those of you who may be interested, you can find detailed information about NDEWS, recordings of prior webinars, and invitations to future webinars on our website at www.ndews.org, www.ndews.org. You will also find instructions there for how to join our NDEWS network and participate in ongoing discussions with more than 1,200 experts and concerned citizens from across the U.S. and more than 20 other countries. Recent topics have included the synthetic opioids and other substances such as loperamide and other kinds of drug-related issues as well. We developed the NDEWS Presents monthly webinars to work with leading substance abuse experts to explore emerging drugs and timely drug-related topics. This month, we will be discussing the National Poison Data System and human exposure cases related to street drugs. This afternoon, we are very fortunate and excited to be joined by Ashlea Zimmerman, who is the Director of Data Services for the American Association of Poison Control Centers, the AAPCC. This webinar will be approximately 90 minutes long, and we encourage questions during and after the presentation. Please post your questions in the Q&A box. We will hold a brief Q&A session after Ms. Zimmerman's presentation. During that time, Ms. Zimmerman, Kathy, and I will do our best to get to all of your questions, and we will also post a Q&A with responses to all questions submitted on ndews.org after the webinar, along with a full recording of this webinar and copies of Ms. Zimmerman's slides. So thank you again for joining us, and we hope you enjoy this webinar. Ashlea, I'll turn it over to you.
Thank you, Kathy. I'm going to start sharing our presentation in 1 second. Start from the beginning, sorry. Okay. Okay, as like Kathy said, I am the Director of National Data Services at AAPCC. So for today's presentation, I will be your resident data dealer. If you have any questions, feel free to ask me during or at the end of the presentation. So before we get started, we're going to go over a little bit about poison centers and our facts. Approximately, we receive about 3.1 million calls annually. Poisonings account for just under 42,000 fatalities, which equates to 1.5 million days of acute hospital care and admissions. That's roughly about 438,000 hospitalizations annually. As you can see from this map, we kind of show that we have poison centers all over the United States territories. The triangles are poison centers, states that have poison centers, and the circles are ones that are serviced by other poison centers. So as you can see, we have all of the U.S. territories covered. So NPDS is an incredibly robust and powerful tool. NPDS is always evolving and adapting to capture new products, drugs, and therapies. So we are a national repository of information about exposure data. We are the only near real-time comprehensive poisoning surveillance database in the US. So on average, we receive uploaded data about every 8 minutes. So some centers are bringing it faster, some are bringing it slower, but on average about 8 minutes. And all of our data is standardized, systematic, and defined data fields. And so whatever we capture from one center, we're capturing from all other centers. We also have product-specific identifiers. So we roughly have about 400,000 products and product identifiers. We also have geocoded data, and we also capture information on calls and exposures. So you can see that we kind of have a variety of ways that NPDS can be applied to various studies. We have studies about exposures, which can be provided prospectively. We also have impact, evaluation of regulatory applications. So like when drugs are reformulated or changed, we're able to track that and look at that moving forward. We also have surveillance data, so we kind of track important things or trends that are happening across the US and across our poison centers. This is all beyond our annual report, which we do publish annually as well, which I would recommend you guys looking at. We're in the early stages of completing that now. And so this slide kind of captures some of our data elements. So we capture age, call information, caller location, caller type. We also have clinical effects, which are signs, symptoms, and lab abnormalities. Relationships to the substance reported. We have 73 therapies, whether the therapy was recommended or performed. We also capture product code information. So this is just one of our data snapshots from our previous year's annual report. So as you can see, basically 50% of our calls are for children who are under 6. And then the next largest category are adults 20 to 59. This table just kind of highlights an overview of the top substances that we get calls about. Related to this presentation, you can see that sedatic or hypnotic drugs represent 7%. So this shows you kind of how we capture our data and how we code for that data. This is an example of cocaine. So while there's no manufacturer, quote unquote, for cocaine, we're able to capture that information in generic coding. And so as new codes emerge or new prescriptions or new street drugs develop, we're able to create coding for that to track and monitor that as well. So this is another example of kind of our generic coding hierarchy. So as you can see, there's 33 stimulants and street drug generic codes. And so we capture THCs, types of marijuana and e-cigarettes, amphetamines, and things like that. So for the purpose of this presentation, when we define street drugs, we're just defining them as any drug or substance taken for non-medical use. And so that's typically comprised of amphetamines, opioids, and psychotic drugs. And so this slide kind of highlights some of our popular drugs that we most likely see calls about. So you can see that we have cocaine, ethanol, marijuana, methamphetamines, methylphenidate as well, THC, PCP. So as you can see, kind of the trends of these drugs are the largest calls we get. As you can see, as time moves on across the time horizon, these kind of calls increase as well. And so this is a GIF that kind of goes over how many cases we get from each state. If you look at the GIF, the colors are cycling through each year, but as you see, the darker the color, the higher the prevalence in calls. So you can see that kind of Texas, California, and Florida, among others, are kind of our largest states. And if you look at 2015 through before 2010, you can see there's kind of a large increase. And so this next slide kind of goes over the top 10 street drug states. And so as you see, the states are pretty much primarily the same. The top 4, Texas, California, New York, and Florida, are kind of always in the top 4, but the lower 6 are typically the same exact states, but they kind of move up in position. So as you look at 2010, there's 3,944 in Texas, but it increases to 4,704 in 2015. And so this slide kind of breaks down street drug exposures by gender through 2010 through 2015. As you can see, we do code for female, male, and pregnant. So pregnant is its own subcategory. As you can see, in 2010 through 2015, there's a steady increase. Males make up the primary contributors to this as well. And so 2015 shows our largest number of exposures, but females are pretty much consistent across the time horizon. And so this kind of breaks down street drugs in terms of seasonality. 2012 shows a break from the previous years. It kind of has a larger spike. Marijuana was the primary contributor of this spike. It also shows the seasonality between drug usage. If you look at the slides, you can kind of see a peak happening during spring break times. And so this slide has a pie chart that kind of breaks down all of the drugs or the primary contributors to the drugs calls we get between 2010 and 2015. Methylphenidate, marijuana, cocaine, and benzodiazepines are some of our largest contributors. And it's important to note how fentanyl is not a primary contributor so far, but as we know that as fentanyl abuse has increased, it'd be interesting to look at that moving through time. And so this is 2015's street drug breakdown. As you can see, we still have methylphenidates, THCs, methamphetamines, marijuana, and heroin are still our primary contributors. Fentanyl is still one of our minor contributors at this point. And so if we look at methylphenidate cases or ADHD or ADD prescriptions, you can see that there is an increase. This peak is between 6 and 12, and it kind of steadily declines. But it's interesting when you look at it, how it kind of dips in the 30s, but kind of increases again in the 40s. Marijuana cases as well. As you can kind of predict, not very many between 5 and 12, but the spike is in the teens and steadily declines from that point forward. If we move on to heroin cases, we can see that there is a huge spike in the 20s. We saw a break from our normal trends in 2015, which is similar to national trends. And so cathinons, or bath salts, as we know them, we did see a spike as well in 2011, which is around the time that they kind of became more popularized. We kind of saw that in social media as well. And so that kind of correlates or follows national trends as well. And so, and this is my contact information if you have any questions as well. And then we can open up for questions.
Cheers. All right. All right, thank you, Ashley, for that presentation. That was very informative. We appreciate you sharing that information about the AAPCC data. Did get a couple of questions in from our viewers today. So the first question is about how you were categorizing drugs in your system, and the question is, why is THC in a different category than marijuana?
We categorize THC in a different category than marijuana, typically because we're thinking about we have marijuana as well as synthetics. So they are kind of captured separately.
All right, the next question is, have you made any comparisons between the states using rates which would take population size into account? And I think you did do this at one point for the synthetic cannabinoids calls, because I remember some stuff from an earlier presentation that you guys made there. But is that a regular thing you do, or do you have anything you could share with folks today?
Yes, that's an option we can do. We can do geocoding, which does take into account populations. So yeah, we can do something like that as well. It would just be something that you'd have to build into a query or request, but we can do that for you as well. And we do provide that kind of information.
So if I remember correctly, in the map I saw for the synthetic cannabinoids, looking at the rates between the states, the higher rates were in the eastern and southern United States.
Yes, that is the emerging trend that we are seeing.
Okay. The next question is synthetic marijuana similar to bath salts? So first off, I guess we encourage people to refer to synthetic marijuana as synthetic cannabinoids instead, because we want to get away from the idea of comparing it to marijuana, because that's not really what it is. So I don't know if you'd like to answer the question.
I'm not a toxicologist.
Okay. The answer is they're not really the same. They are both substances that did start to come up around the same time and can often get marketed in similar ways and similar kinds of packaging and be used in similar ways. But while synthetic cannabinoids tend to try to mirror marijuana in their effects, the bath salts tend to be closer to stimulants.
Thank you.
So the next question is, do any of the poison control centers collect data on opioid overdose reversals through the use of naloxone?
We do collect information on naloxone, and yes, we do collect. We actually do. We have some long-going studies, actually, which we do track and review opioid overdoses, as well as the reversal medications. So naloxone, we do collect data on that as well. So we do have a pretty robust set of information about those.
So if people were interested in that, could they just get in touch with AAPCC? And would you have anything you could share?
Yes, definitely. If you can get in touch with me, or you can check out our website. We do collect information on that, and we can provide you with data related to that.
Okay, thank you. So the next question is, do you collect sub-state information such as county level data?
I don't think currently we do have county level data. We do have, but it can be collected based on like geocodes or, zip codes. That is a way to track it. So we can track it that way. So not necessarily each county, but each zip code. And so you can break it down that way. So yes, we can do that.
And I think also if you get in touch with your local poison center, they may be able to help you out with that. Because I know here in Maryland, for instance, I have been able to get information from the Maryland Poison Center and also from the National Poison Center in DC, where they can break things down. So I think there are often ways to do that. Let's see. The next question is, we're getting questions in. This is good. So the next question is, will you make the slides available to webinar participants? And the answer is yes. We will post the slides on the NDEWS website at www.ndews.org. And we usually get that done within just a few days of the webinar. And the next question is there a report containing the data on trends in street drugs available on your website? Can you produce the tables or graphics on a regular basis?
So we do have some data on our websites related to street drugs. We do have some data available in table forms in our annual report, which I would recommend you guys look at again as well. It does have some information related to that as well. We don't have graphs updated like on a quarterly basis on our website, but if you send me an email, you can request that from me and we can help you get that.
Okay, thank you. It looks like we just have a couple more. This next one is a comment from the Maryland Poison Center that the Maryland Poison Center and some of the other centers collect additional data on bystander and law enforcement administration of naloxone. So that gets it an earlier question that came up. So thank you for sharing that. And the next question, are you able to test for the new street benzos that are usually not revealed by the urine drug tests?
As long as we create new coding to track new things as they come up or they emerge. And so if a new type of benzo that is not previously being tracked or we're not being able to record, we are able to create coding for that. But if it's not in a file, then we don't pick that up.
All right, thank you. And I think we have one last question here. Will fentanyl reported numbers go up with testing abilities?
I would think so. I mean, that's one of the things we're very interested in looking at moving forward is fentanyl, since it has become a larger problem. So yes, we are looking at that. And we do keep, actually on our website, we do have some stats on fentanyl.
All right, thank you. That looks like it's all the questions that we got this afternoon. And so again, thank you, Ashlea, for doing the webinar for us today, and also a big thanks to AAPCC for being partners with us on NDEWS and working with us so regularly the past year and a half to share information and help us collect information on new emerging drugs and drug trends. We have certainly found the partnership incredibly valuable here at the Coordinating Center, and look forward to continuing to work with all of you guys there. And so the next, whoops. All right, sorry, went by too quickly. The next webinar that we have coming up will be in June, and it will be with our colleagues up north in Canada. And it will be Matthew Young, who is from CENDU, the Canadian Community Epidemiology Network on Drug Use, and the Canadian Centre on Substance Abuse. And hopefully he may have a couple other colleagues from Canada with him as well. And they will be talking about synthetic opioids and counterfeit pharmaceuticals and other illicit street drugs, the situation in Canada, because we have noticed that there are some interesting commonalities and differences between our countries, and when and how things show up and what we see in different places. And so that should be a very interesting webinar as well. And before I let you guys go, we would like to do a brief poll. And so I'm going to pull that up now. And if you would please just take a minute or so, a few seconds to answer our questions, I would certainly appreciate it. NDEWS at umd.edu. All right. Looks like there might still be a few folks out there voting. Seems to slow down at this point. Okay, well, I'll wrap things up, and if anybody else has any questions out there or has any interest in additional information from AAPCC, you can certainly get in touch with us here at NDEWS, and our email address is ndews@umd.edu, ndews@umd.edu. And so if you send your questions or inquiries to us, we will certainly get in touch with Ashlea and her colleagues at AAPCC and see what we can do for you. So thanks again for joining us, and we hope to see you again next time.